Hi, I'm Samantha Womack. I'm a mother, I'm an actress, but I'm also a survivor of breast cancer, and I'm absolutely passionate about helping people battle this disease. That's why I'm here at Imperial College to talk about Digistain, which is the brainchild of clinical scientist Dr. Hemel Amrania. It's a revolutionary new AI diagnostic technology to help people understand their cancer and the treatment that will benefit them.
So, Sam, thank you so much for joining today in support of Digistain. Tell us about your journey.
So about 6 months ago, I was working on a production in the West End, and I had a kind of sixth sense, if you like, that I needed to get a well woman check. I didn't have any symptoms or signs, but I went for this check, and during one of the ultrasounds, discovered a shadow, and then through various different testing methods, finally got a diagnosis of a high grade 2/3 breast cancer. And then, as you know, the very complicated route then of trying to understand how my cancer was progressing, how aggressive it was, and therefore what treatment I needed was actually quite a complicated route. For me at the time, I didn't have any private healthcare, but I decided to have a test that's available to me at the time where I sent off a sample to the US, and that took up to 6 weeks to get the result back, and it was very expensive. Sometimes the NHS will provide that test, but in very specific circumstances. So my passion about listening to Digistain and all of the statistics that you were able to give me was that at that time Digistain could have actually given me similar results, but with no waiting time and certainly a lot more cheaply. Is that the case, and how would it have worked for me?
Yeah, so I would say a lot of people that I speak to are shocked to learn, very much like myself, that the biopsies are being sent off all the way to California on a
Yeah.
daily basis. Like when I was at the NHS, um, I remember speaking to one of the clinicians there, and I asked him that this patient here is an ideal candidate for this test. Why don't you just get this test? And their response was, look, Hemel, just because this is the right test for the patient doesn't mean we can afford to
Right.
send them off. So it's a really great point that you raised, Sam, about the accessibility of some of
Yeah.
this testing. I mean, you had your sample sent off privately.
Yes, I
Yeah.
did. And that was a shocking factor for me. I think as a patient, you always assume that the tests and the treatment that you are getting are the best available to man, but actually we have to be more realistic than that, and it's all about cost. Um, I was certainly shocked to learn that chemotherapy for each patient is up to, is it £80,000?
When you consider the full economic cost
Yeah,
of the chemotherapy, the administration of the treatments and everything, the labour behind it, yeah, it's the
absolutely.
biggest cost centre in the NHS.
And certainly for me, when I sent off for my particular test and it came back, and I was borderline as to whether I would need chemotherapy or not, but I decided to have a couple of sessions just to see how it was and how it affected me. And it is a terrifying procedure and incredibly strong, right? So the way it works is it kills the cancer cells, but it also kills a lot of other cells as well. And I could feel by my second treatment that I was really struggling physically. Now, I understand that that's absolutely essential in lots of cases, but presumably Digistain, the most important thing is we're not going to over prescribe that particular drug if people don't need it. And certainly for me, that would have been really great information to have got more easily. And that's what we want for people, right?
We have gotten better at identifying patients who can be spared from chemotherapy.
Mm.
And indeed, that's the reason why samples are being sent off to California
Hmm.
to identify those patients
Yeah.
who can safely proceed without aggressive chemotherapy in favour of more conservative endocrine therapy.
And that's by uh, correct me if I'm wrong, but that's the procedure is you take a slice of the tiny amount of a person's tumor. That tumor is then looked at in a very specific way. And with Digistain, it uses AI intelligence to set up a program to help you read, is it how aggressive the cancer is, or? and whether the treatment needs to be aggressive or less so.
So what we did is we took a proprietary spectroscopic signature
Mhm.
from the cancer sample itself from biopsy, and then linked it to patient outcome in a huge training set so we can work out if every time we get a new sample,
Mm.
which category it falls into.
Right.
Is it a patient that's going to have a good prognosis,
Yeah.
or is it somebody who's going to have a poor prognosis?
Yeah.
And what we did is we went out there and surveyed over 1,500 breast oncologists to really dig deep and find out specifically what kind of patients they struggle with
Mm.
in determining the best course of therapy. And it turns out to be these hormone positive intermediate risk patient who,
Which I was, yeah.
to be. Um,
And that's because the information they get is not clear, even with the first and second test. That information wasn't clear enough. So it was a grey area, maybe as to whether. So really, then at that point, it has to be a one size fits all. Well, we don't have real clarification, and so therefore we may as well administer harsh chemotherapy because they were lacking that clarity.
that's right. So in the olden days, we used a technique called HME staining. You take a sample, you dye it with a couple of vegetable dyes, and
Mm.
literally put it under a microscope for a pathologist to review.
Mm.
And that is how the cancer is diagnosed. That is how we work out how aggressive, or how we deduce how aggressive the tumor is.
Mm.
And then the therapy is based on that pathologist's report.
Mm.
And over time, we realized that there's poor concordance generally between different pathologists on what is a high risk, borderline
Mhm.
high risk case, or what is a moderate risk case.
Mm.
So 20 years ago, there was this genomic testing that came about,
Yeah.
really to tackle that problem. The problem that exists today is that clinicians are becoming more and more reliant on these genomic risk profiling tests,
Yeah.
but they're so expensive and it takes and so slow.
And at the moment, we can't access that here in the
No,
UK. The only place we're getting that information is to send it away, and it's up to 6 weeks. I know myself, I had to wait over 4 weeks for that result to come back, and that's for a patient who is spending a lot of their time waiting. That's a really terrifying time because essentially you're waiting to find out not just what your treatment is, but what your prognosis is. So for me, it would have been so much easier to have had that technology available to me because you're able to test there and then in the hospitals with that tumor sample.
yeah. So having gathered all the data from the surveys, from the research that we did,
Mm.
we figured that it was the right time to serve this need for clinicians and for patients like yourself who are
Mm.
sitting there waiting for weeks to get results. Uh, listen, look, this, the data behind some of this testing is fantastic. It's
Yeah.
great, but it's clear as day that there is a huge need to solve this inaccessibility problem.
Mm.
Even in the UK, which is a great healthcare system,
Mm.
there are parts of the UK that where communities don't get access to some of this testing because it's
Yeah.
just too expensive.
Yeah.
And even when these tests are approved in the UK,
Yeah.
they've been approved for a particular kind of patient
That's right. I remember that. So if you meet the
if you meet the
criteria,
criteria.
and that's quite a small criteria. So if you don't meet that criteria and you don't have the funds yourself, you're never going to understand really how specific the treatment is tailored to your individual cancer.
That's right. So the criteria are fairly narrow,
Yeah.
particularly compared to other healthcare systems around the world, like in the US, where the criteria are far wider.
Right.
Far more patients are eligible for this kind of testing. And the reason for this is because, the NHS is great, it's got a job to do, but
They're
quite frankly,
limited
they're
with
limited with
funds.
resources, absolutely.
Yeah.
So that's our raison d'etre, if you like, to try
Mm.
and solve this inaccessibility problem with something that's far quicker and far more accessible because it's far more cost effective.
And that will help the NHS in the long run because, of course, £80,000 per patient for chemotherapy, if it's not needed, is an unnecessary waste of time and money for them.
Yeah, absolutely.
And so, How far along the way is Digistain here in the UK? Are people able to access it in some parts of the country, or how far away are we from being allowed to have that testing done?
So here in the UK, we're already serving patients privately, and they're being commissioned by the NHS. They've set up small programs to help innovators like myself to access the NHS from within. So we've got that backing now, and now we're finally making traction. In fact, I was approached by a hospital very recently who's now decided to commission this test in the NHS.
That's fantastic. So it's approved. It's not a kind of scary new thing that's still in its kind of investigative stages. It's fully realised, and now we want to help people not just be able to get it privately, but within the NHS. So it's available to all women and actually men who also suffer from breast cancer, which was something I was surprised to learn as well. So
That's right, yeah. So most people don't talk about the male breast cancer cases. It's true they aren't as common as female breast cancer, but it is a concern, and it's a concern that a lot of clinicians are um, are faced with. So we're actually conducting trials right now for male breast cancer cases as well.
That's fantastic. And just to clear up for me, the amount of cases that are diagnosed each year. So each year in the UK, it's 55,000 people
It might be a little bit more than that now. The numbers are creeping up. So
Right,
it might be a near around 60,000 cases.
right. And that also will lead to around 11.5 or 12,000 deaths a year, which is a lot. That's a high number of people. So presumably this information, if we get it more quickly to people about their cancer and what it needs in order to diagnose it, that will presumably result in lives being saved.
For sure. So there's a statistically significant link between the time for which treatment is delayed and patient outcome. So anything we can do to improve patient outcome by reducing that time to treatment with a turnaround time, with a test that has a turnaround time that is far shorter than current standards, it's the best thing we can do.
And also, it's right to say that in some severe cases and aggressive cancers, chemotherapy is wonderful and it does great work. But when it's not needed, it's a very strong treatment, which itself carries quite a few risks. And so we don't want people having chemotherapy if they don't need to. Statistically, and I don't know if this is right, I was shocked to learn that a large number of deaths with cancer are actually attributed to chemotherapy if it's not used absolutely necessarily.
For sure. So back in 2008, we in the UK commissioned uh, a wide-scale national study, investigation, if you like, to see the effect of chemotherapy on outcome. It turned out that it was determined that 27% of cases, chemotherapy was primarily responsible for either the death of the patient or for hastening the death of the patient. Now, back in 2015, when I was working at Charing Cross, just before we launched Digistain as a means to tackle this problem, I remember going through patient trials and working my way through patient reports. And it was my job at the time to find patients that were suitable for this technology. And going through a patient file, it's a harrowing experience. Working through the patient notes,
Their personal story.
their personal story. And it was difficult to read because the patient would be talking to the doctor and it was all noted down, reported, and then by the end of the file, the chemotherapy is clearly killing her.
Because is it right to say that new medicines, and we're very lucky at the moment with cancer that there's this wave of new treatments coming, which are all based around immunotherapy. Presumably, that is very different. It's a different way of treating cancer because we know that chemotherapy is a poison, it's a toxin.
It's a broad spectrum.
It's a right.
Tactic, yeah.
Right. So what we're trying to do is, if it's not needed, is that we're trying to actually boost the patient's immune system, and that would be very hard to do if it had been battered by an unnecessary toxic drug. Well, I just want to say thank you for allowing me to be a part of Digistain's journey. Obviously, personally for me, I would have loved it if Digistain was around to give me a diagnostic result, but hopefully by us doing this, it will be available to millions of people eventually around the world. So thank you.